Hello and welcome everyone in Medicine in Minutes in our first video, which will be about Wilson's disease. Wilson's disease, or hepatolenticular degeneration. It's due to a genetic abnormality inherited in an autosomal recessive manner that leads to impairment of cellular copper transport. In epidemiology, men and women are equally affected, although women are more likely than men to develop acute liver failure due to Wilson disease. In physiology, normally approximately 60% of ingested copper is absorbed in the stomach and duodenum, loosely bound to circulating albumin, and then transported to the liver. Within liver, copper is incorporated into an alpha-2 globulin to form ceruloplasmin. The ceruloplasmin is then re-secreted into plasma, where it counts for 90 to 90% of circulating copper. Normal total body copper is estimated at 50 to 150 milligrams. Unabsorbed copper are secreted into bile and excreted in stool. Stool, which is the primary route of copper elimination. Remember that renal losses represents 5 to 15% of daily copper excretion. Now we're gonna talk about pathogenesis. Impaired biliary copper excretion leads to toxic accumulation of copper in several organs, most notably the liver, brain, and cornea. There is also increase in copper absorption from the small intestine. Over time, the liver is progressively damaged and eventually becomes cirrhotic. Speaking about clinical manifestations, there is wide variability in the reported rates of the different clinical manifestations seen at the time of representation. 10% of patients have a psychiatric disturbance. Kaiser-Fleischer rings in the eye on slight limb examination. Some flow cataract in some patients. In addition, there is tremor and Parkinson's occur in one-third of all patients. Fanconi syndrome and type 2 proximal renal tubular acidosis develop because of copper deposition in the kidney. Occasionally, there is a hemolytic anemia when the copper levels go high and are toxic to the red blood cells. And don't forget that there is movement disorder due to basal ganglia dysfunction. In diagnostic approach in lab, liver biochemical tests increase, complete blood count in red cells count decrease, serum ceruloplasmin decrease, which is the most specific blood test. But don't forget that low ceruloplasmin alone is not enough to diagnose Wilson disease. Serum copper levels decrease. 24-hour urinary copper excretion increase. Liver biopsy is the most specific test, whereas the serum ceruloplasmin was the most specific blood test. Patients with indeterminate results will require additional testing such as liver biopsy with copper quantitation or molecular testing for ATP7B mutations. So don't forget that copper in urine increased but in blood it's decreased. Eventually, we're gonna talk about treatment. Lifetime therapy aimed primarily at treating copper overload is required in Wilson patients. And there are two phases. The first one is removing or detoxifying the tissue cover that has accumulated, and the second is preventing reaccumulation. Cover removal is achieved by the administration of potent cleaters such as dipenicillamine, triatin, oral zinc, which is interferes with copper absorption. Steroids will not help. Liver transplantation is curative. Thank you and appreciate your watching and listening.